Okay, so this is a pre-recording for the antiviral and antiretroviral. So I'm going to, let's turn off okay. Okay, so I'm going to start, this is chapter 6. So I'm going to get started on this one. Okay, here we go. So you have your antivirals so this chapter 6, antivirals and um, retroviral. So again, you always want to make sure you know your key terms for all of this. Um, so, so your antivirals. What is a virus? So a virus is a small. So we went over the bacteria before. Now we're going over to virus. So we're looking at the virus. So a virus is a small infectious agent that can reproduce only inside other living cells of a host organism, which includes the human cells. So viruses consist of RNA and also the DNA genetic material and are surrounded by like a protein or a fatty or a combination of that coating known as what is called a capsid. So what happens, this virus inserts its own genetic information into the host cells in the nucleus. So basically, it's going to hijack the cell's function itself. So it's going to basically, just like looking at one of those sci-fi movies where they go into the person, or or the person's possessed because they put their own self in it. So the basic cell that function that the cell already had is basically is going to change. So that's the difference between the bacteria, because the bacteria is going to surround it, make a fort around it. So you have to use those antibiotics to go in and try to either stop it, the formation of it, or to kill it itself. So this one is basically is going to change the cell's function. So this causes the host cell to produce and release more of those virus particles, those virions, so the infection continues to spread that way. So basically, once the person is possessed, I'm going to use that word, or change their whole identity change. Now they're going to tell the others, like get them to be infested or possessed with this too. So basically, you're going to have this damage, the breakdown, eventually death of the infected cell itself occurs with this whole viral infection. So the viruses, they cannot survive or reproduce without the host. So they need that host. They need something to actually keep them alive. So the viral infections are not killed or suppressed by antibiotics. At all. So the only drugs that are capable of interfering with the ability of the virus to carry out its reproductive functions are those antivirals. So what does the antivirals do that's different from what an antibiotic can do? Because the antibiotics, again, it cannot kill a virus. It cannot. Only antivirals can do that. So antiviral drugs are used to treat a variety of common conditions caused by these different viruses. Um, and these include viruses that cause like the herpes zoster, the herpes simplex, the genital herpes, the varicella, and some influenza infections, and the hepatitis B and also C. So the antiviral drugs must enter, okay? So this is what they do. So your antiviral drugs, they're going to enter, they're going to boom, 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 walk right in to these antivirals, they and act at the site of infection to be effective. So the antivirals do not kill the virus, but rather stop the production of it, stop it from going to the next one and going to the next one to like make it, to slow it down. So this means this action means that all antivirals are only viral static and not virucidal. Like the bacteria static, you have bactericidal. So you're only going to see the viral static and not the virucidals in these. So they only stop it, inhibit it. So these antiviral drugs work in a variety of ways. Number one, um, by blocking the virus, number one, from entering the host cell, and also by targeting these enzymes and proteins inside the host cell that allows the virus to replicate, to change over, to reproduce, and leave the infected cell to then find new cells to infect, or by helping the host immune system fight this viral infection. So you do have some antiviral drugs for different um, usage. And one of them, so under the antivirals, you have antiviral drugs for herpes simplex virus infections. And so when you look at herpes simplex, you know, um, so when you look at the herpes simplex for viral infections, you have herpes simplex type 1. It's the virus responsible for the cold sores of the mouth that you probably heard about or seen. So these infections can become widespread. You see them in newborns or anyone who has an immune system that's not actually functioning well. Then you have the herpes simplex type 2 virus, which you'll see as HSV2, and the other one is the HSV1, by the way. So the virus is responsible for the genital herpes infections and lesions. So just like other viruses, once a person is infected, the viruses are always present in some type of tissue. So it's like, again, it's only stopping it. So sometimes this is why you see it reoccurring again, and you have to take the medications over again. So however, your book states this, quote, however, actual symptoms come and go in patterns. These are called your outbreaks, okay? So an infected person is going to be more likely to spread the infection to other people just because symptoms are present and during these outbreaks. So outbreaks are uncomfortable and they do have their consequences. So the goal of the HSV antiviral therapy, is to really just kind of prevent the outbreaks or reduce the frequency or the intensity of those symptoms that the patient may have. Okay, so and basically what is that going to do? It's going to reduce the spread of the disease. So you do have those actions. So, each one have their, so these antivirals for the influenza and also the herpes simplex virus, they do have their actions. And you do have your common antiviral drugs that we're going to look at right now. And they are viral DNA polymerase inhibitors that work, again, to reduce the viral reproduction by forming a counterfeit molecule that block the virus and its enzyme from making more genetic material and variants in an infected host. Without the genetic material, the virus cannot reproduce. So again, the only way a virus can reproduce is by being in this host. So what these antiviral drugs go in, they make like a counterfeit molecule to kind of trick that virus. And like there are a host, but it's a different type of host. It's a host that's like, oh yeah, you can come in here, but I guarantee you're not going to reproduce or do anything to damage everybody else that's in my house. So that's that kind of antivirus. So the antiviral drugs for influenza that you will find under the neuraminidase inhibitors, that type, you're going to see your Tamiflus, you're going to see your Relenza, so you will see all of that. So your nursing implications will be before giving these medications, you want to ask the patients whether they have any type of asthma, because this is orally inhaled. So the orally inhaled drug can cause some type of bronchospasm. Um, and so that's one of the nursing implications for that. And then you have your uncoding inhibitors. And with the uncoding inhibitors, it's needed for the viral fusion with the host cells. Like it's basically the first step of the cellular infection. So what these inhibitors do, they prevent the initial influenza infection and spread of the influenza infection by interfering with the viral coding. And again, one of the nursing implications for that would be before giving either of these drugs, you want to ask the patients about all other drugs that he or she is taking, that he or she is taking. And, ooh, my throat is so dry. That he or she is taking, and check with the pharmacist because of the numerous possible drug interactions with those. And also you want to observe your patients for any type of confusions or hallucinations. And because those drugs cross the blood-brain barrier and can cause some type of central nervous system side effects. Then you have the drugs that fall under the viral DNA polymerase inhibitors. And these drugs work to reduce any type of viral reproduction from forming again that counterfeit effect. Okay, and this is where you have your enclavirs, your famciclovirs, and another medication called the valacyclovirs. And with the valacyclovirs is one of those that patient takes to prevent persons with the herpes or spreading to as an unaffected sexual partner. Again, you want to review the nursing implications for those. Okay. Then you have some other antiviral drugs. So those antiviral drugs for influenzas, I did go over some of the actions already and the uses. So now you have your antiviral drugs for the cytomegalovirus or the CMVs or your RSVs or your respiratory syncytial virus, where you see a lot of times produced in children and the elderly. So the antiviral drugs for the cytomegalovirus or the CMVs. So let's look at the cytomegalovirus. Cytomegalovirus. So the cytomegalovirus or the CMV, that's your virus from the herpes family, and that infects the human cells. So usually in people who have a fully functioning immune system, the CMV infection causes few problems and may go unnoticed. But if you have, but the persons whose immune system is not functioning well, like the people you'll see with AIDS, even in newborns, or people who are immunosuppressed because they are on chemotherapy, the CMV infection can cause serious problems. And one of those would be encephalitis, which is a brain infection. And this can lead to brain damage and even death. It can also lead to retinitis, which is an eye infection, and this can lead to blindness. With the RSV, that's a respiratory. So when you think of respiratory, when you think of RSV, of course, that's going to be the respiratories. So the respiratory, and also when you think of the cytomegalovirus, that's one of the torches. Okay, you remember your torches, the toxoplasmosis, so C stands for the cytomegalovirus itself. So that's what that is, okay? And remember with the cytomegalovirus, when you're thinking of your torch, that's the drugs of choices will be the antiviral drugs. And when you think of the toxoplasmosis, those were your, the other category of drugs that we just got out of. The not antifungal, but we were under, you can go back, but the toxoplasmosis fell under that one. Okay, but the cytomegalovirus is an antiviral drug. Okay, so now, so your RSVs, the respiratory syncytial virus, this is a common respiratory virus that infects the lungs and also the bronchial tube. So it's a very common cause of like you hear the chest colds, you hear the babies probably like that disease called croup, which we'll learn about in pediatrics, and even pneumonia in children. So the RSV, you will see this in a lot of the children when they go into the emergency room, because sometimes they'll check to see if the child has the actual flu itself, but then again, it can just be the RSV. So for healthy people who have a good immune function, the disease is, you can see a more milder symptoms in adults. And a lot of the people usually recover from this like 5 to 7 days without any type of treatment whatsoever. But when it comes to more like these small infants or a premature baby, you know, it could be more chronic. Also in the elderly, you can see who have the weakened immune system, or someone who has a weakened immune system, the respiratory infection can be very severe to them, and this can also lead to death. So with the actions and the uses of these drugs, with this for to treat the CMVs and the CMV, come, so, you know, the drugs to treat them come with a viral DNA polymerase inhibitor class, those type of drugs. So those drugs, they basically inhibit the viral enzymes need to make more DNA for the viral reproduction. So as a result, you have the fewer variants are made, and the infection of the symptoms begin to subside. So those drugs are also used for the purpose of, your book says, the Vistide and the Fosavir, and they are both extremely toxic and has to be given intravenously, and are used on a short-term basis to reduce the infection symptoms. So you do have a list of in table 6.2. It talks about those two classes of drugs, and make sure you read the nursing implications, because one of them is do not mix these drugs with other drugs because they are incompatible with most other drugs. Again, this is how this whole thing works, about the infection and the cellular outcomes of HIV and how it all works. But all if you can, you know, if you have time, you can kind of just look through that. So you also, and then you also have your categories for the RSV. So now we're going to look at the antiviral drugs for hepatitis B and also hepatitis C virus. And those drugs are used to treat the hepatitis B. They fall into three classes, which are your nucleosides, transcriptase, the NRITs, and the DNA polymerase inhibitors and interferons. So when you're looking at the antiviral drugs for the hepatitis B and also the hepatitis C virus, so just a little overview for your hepatitis B drugs, which is the hepatitis B virus, which is HBV, and then you have the hepatitis C, which is HCV, are both hardy viruses, and they can live in a variety of environments, and both in, you know, throughout the United States, the common ways these viruses cause infection is by blood-borne route and also sexual transmission. So they both have a long incubation period, which is from anywhere from 2 to 26 weeks. After infection, followed by a first acute illness, and then often a chronic illness after that. So the major drugs used to treat HBV, they fall into these three classes, which I just showed you. And so basically the NRIT drugs, or the nucleoside reverse transcriptase inhibitors, you know, one of them is called the lamivudine. So within that whole class of drugs, is used as a part of treatment for HIV infection and also AIDS. So you'll see that as we go through the class of drugs. So let's look at these drugs. So you have these drugs for the hepatitis B and also hepatitis C. Where is it? Hepatitis B and hepatitis C. And so you'll see those different categories of drugs under the DNA polymerase inhibitors. And so again, your nursing implications, here's one of them. And you want to assess the patients for yellowing of the skin and also the sclera and elevated liver enzymes, because these drugs are toxic to the liver. And then you have your proteinase inhibitors. And again, one of the nursing implications for that would be to assess the patients again for the yellowing of the eyes and the sclera, so which is the same thing. But you also want to teach the patients to protect themselves from the sun with clothing, hats, and sunscreen, because this drug increases sun sensitivity and can result in severe sunburn. And then you have your combination agents. And when you look at the combination agents of these drugs, so basically this drug is now reported to cure the hepatitis C, and that is your lettuce-pazvir drug, that medication. And so it's a cure for hepatitis C. It's a combination of the antiviral agent containing the viral protein inhibitor, pazvir, and the viral DNA polymerase inhibitor, which is the sulfobuvir. So you have those two drugs in a combination together that is now reported to cure hepatitis C. Okay. So of course you're going to have your general antiviral expected side effects, the adverse reactions to those drugs. So again, you just really want to make sure you take a look at those. So one of the expected side effects to the antiviral is going to, again, your nausea, your vomiting, your headache, and then, and some of the adverse effects, that you're going to read when you're going through the whole nursing implications. But you always want to look up and be aware of the rashes, the hives, difficulty breathing, and also facial swelling, just in case they have a hypersensitivity to the medication itself. And many of the antivirals are also have like the drug interaction. So as antivirals become more widely used, these interactions is going to begin to increase, and people are going to begin to report more. So you always want to document what side effects the patients may tell you. And again, those nursing implications, you always want to make sure that you're reviewing that. When you're looking at retrovirus, the organisms that transmit their own information into the cell's DNA. So the retroviruses are organisms that differ from viruses, and that instead they are merely hijacking a cell's DNA or the RNA to reproduce. So they transmit their own information into the cell's DNA. So normally cellular DNA is unzipped by an enzyme called transcriptase and then transmitted by RNA to the ribosome where protein synthesis can take place. So the protein is basically the building block of the tissues, and it needs the DNA needs the DNA information in order to form. So what the retrovirus does, the retroviruses carry special enzymes like the reverse transcriptase and the integrase and the protease. So with them, and so they have that, and they use the RNA instead of DNA as their genes. So the retrovirus inserts their own genetic material into the host DNA from its RNA. So in this way, the retrovirus can expand and multiply all the while using the host cell's metabolic system and making those virions, those new viral particles that can leave the cell and infect more cells. So you'll see this in HIV. So the HIV, is the retrovirus responsible for the immune system problems when infections with this organism, when the infection with this organism results in HIV disease and it begins to progress to AIDS. So once the person has become infected with HIV, they will have the virus for life. So the HIV begins to attack the body's what we call that CD4, which you probably learned about in MedSurg, or the helper T cells that are responsible for helping the immune system fight infections. So if the HIV is untreated, the decreased number of CD4 cells in the bodies make the person more highly susceptible to the infections, such as like you see in tuberculosis or other viruses like the CMVs and the cancers like the non-Hodgkin's lymphomas. So again, those are opportunist infections. They signal that AIDS has developed in the person when they see all of that developing. And so so with the AIDS, it's the later stage of HIV, and it can cause a breakdown in the immune system, which leaves the patient unstable to fight any infection at all. Okay? So again, those fall under the retrovirus. Um, so, um, so what do we use? You have those antiretrovirals that are used. So the action. So basically, what the antiretrovirals, what they are going to do as they go on. So they are a very important group of drugs that slow the growth or prevent the duplication of those retroviruses, and they are used to limit or slow the advance of HIVs and its progression to AIDS. So the antiretroviral drugs, basically they are used for treating the patients with the HIVs or for adults and children at risk for acquiring the HIV and AIDS. They are not going to cure HIVs, and they do not cure AIDS, but they do help the patient live a longer, healthier lifestyle by interfering with the ability of this retrovirus to replicate or aka reproduce. And they're going to do this by slowing down the production of these retroviruses. So all antiretroviral drugs are, again, they are viral static. They don't kill, they just stop, okay? So basically, so you have the drug for the HIV infection and AIDS. They do work best when several different types of antiviral drugs are basically all working together. So this therapy is like a known combination of antiviral therapy, or we call it the CART, with the C being small and everything else is capitalized, which is CART. So you have the 6 categories of the antiviral drugs, which are the non-nuclei reverse transcriptase, what we talked about earlier. But this one is the NNRIT with the non. The other one with the just a regular N. Um, so um, so so these are so in table 6.4. Okay, well, table 6.4, you have your examples of the antiviral drugs for the HIV infection. You have those different types of drugs. So these drugs, again, are a similar structure to the 4 nucleotide bases of the DNA, making them the counterfeit bases. So they do fool or play with or trick the mind of the HIV enzymes by reversing the transcriptate into using these counterfeit bases, so that the viral DNA synthesis and replications are basically suppressed. And so these NRTIs are oral drugs. So again, make sure you look at these nursing implications and the patient teaching. So adherence is essential. They got to adhere to this medication. Medications do not cure. Report all drugs and supplement use, including over-the-counter and the CAMs, or what is it? I forgot what the CAMs, like the combined drugs medication. Okay, signs and symptoms of pancreatitis, signs and symptoms of peripheral neuropathy. So you want to make sure that you teach them the precautions and the injuries, because these drugs can induce the whole peripheral neuropathy. So you want to make sure you know your signs and symptoms for that. And then you have a whole other list of category of drugs that fall under the NN RTIs. So you have those. Again, you want to look at the nursing implications for that, and your protease inhibitors, and the nursing implications for that. And so it's a whole list of different types of drugs within this category. Again, as a memory jogger, it gives you the 6 categories of the antiviral drug therapies. So it's a lot of different drugs. And also make sure you look at the pregnant and the pediatric life considerations for those. So you have your actions of drugs used for that. Okay, so we went through that. And and we went through the nursing implications. Okay, great. Teaching. Okay. So again, it's a lot of drugs within this category. When you want to study all of this, again, it's really great to look at the lifespans and the safety alerts and the nursing considerations for with the drugs within or the whole category itself. Okay. Okay, so now chapter 7, drugs for um, allergy and respiratory problems. Okay, there we go. Drugs for allergy and also respiratory problems, chapter 7. So, of course, you're going to have, this is like really the time and the season for like everything. So, this is definitely the time and the season for your allergies and for like respiratory problems. So I'm not going to go over the whole anatomy and physiology of breathing and the lungs, so you can kind of read that yourself. But oh, we already did this. I'm looking at this. I'm like, wait a minute, why it look like I'm talking about the same thing? So let me pause this. Okay, chapter 14. So these are drugs affecting the hematologic system. Okay. Blood clotting. So all those words I said before in regards to the cumin and the warfarins and all that stuff, that falls under this category. So you have the drugs affecting the hematologic system. Okay. Okay, so I'm not going to stay on this chapter too long. So you have all your anticoagulants and your, everything else here. So basically, you have the blood clotting. So when you look at the body, so the ability of the blood to flow freely through those whole blood vessels is very critical, basically providing the cells and the oxygen and the nutrients and removing the waste products and all that. So, but what happens if the blood vessels are damaged? If it's damaged, it's going to cause this clotting formation and to, prevent the body from circulating and doing all that great stuff. So it's going to affect the body a whole huge lot of ways, especially if those clot formations begin to start. So what happens if it's a clot? A clot is basically a semi-solid amount of coagulated, thickened blood that blocks. So it's going to block the blood flow. So it's going to block and cause a lot of difficulties. So many times the body, when it happens, it can unbalance the body. So these clot formations can cause a lot of injuries, like, blood circulations going to the lungs and so forth, and causing difficulties with that. So one of the body's protective functioning is to clot. So one of the bloods in your book, quote, one of the body's protective function is to clot blood in response to any type of tissue injury. So any damage to the cells starts a series of reactions to protect the body. So a variety of clotting factors made by the liver are present in the body's blood to act quickly in an organized series of events called a cascade that results in the formation of blood clots. So specifically, tissue and blood vessel damage results in the formation of that thromboplastin that you heard about, which then acts on the prothrombin in the bloodstream to form the clotting factor thrombin. So your thrombin, what is that? That's an enzyme that then acts as on that fibrogen, that protein found in the blood plasma, to basically convert to a fibrin, which is a net-like substance in the blood that traps the blood cells and platelets to form the matrix or frame of a blood clot. So you have this thing called vitamin K, and it has to be present to produce that prothrombin and other clotting factors that are made in the liver. So in addition to calcium clotting factors and red blood cells, platelets and magnesiums are also needed in that whole clot formation. So as part of the circulatory system, the arterial vessels, basically they carry oxygenated blood throughout the body. So if these small articles become plugged with that whole clot, with that thrombi, oxygen is not going to be able to get to the tissues, which can cause death, and so that's not a great thing. So abnormal blood clotting may produce a thrombus, which is a single clot, and can go into the coronary artery, which nourishes your lovely heart muscles. And then you have this thing called an emboli, which breaks into small pieces of blood clot, and these can break off from the site of that thrombus or thrombophlebitis, which is the inflammation and blood clot in the vein. And these can go into your lower extremities and travel through the bloodstream, and it can block these vessels in the brain and even the lungs. So in the brain, this blockage can cause a stroke or death. And in the lungs, these blockage can interfere with oxygenating the blood. So this, therefore, is when you need what we call anticoagulants, okay? So the anticoagulants, these are drugs that interfere with one or more steps in the blood clotting process. And these drugs can reduce and prevent all these new clots from forming, and it can also help to prevent existing clots from getting larger or extending out and breaking into those little, pieces. They cannot dissolve formed clots. So if the clots are already formed, they cannot do that. So anticoagulants are mistakenly called blood thinners, but they do not actually thin the blood. So drugs that act as anticoagulants are classified as platelet inhibitors, or direct thrombin inhibitors, or indirect thrombin inhibitors, and vitamin K antagonists. So these are those drugs. So your anticoagulants in your book is on table 14-1. And you see them as so the anticoagulants, when you have them, and under one of them you got your platelet inhibitors and what they do. So your platelet inhibitors, these drugs use a variety of mechanisms to prevent platelets from sticking together or aggregating together to form a platelet plug that starts a blood clotting cascade. So those are your aspirins, your Plavix, so your Ticklets, so you see those. Make sure you look at the nursing implications for those, because you're going to have the expected side effects like the bleeding and the bruising, your adverse effects such as your some more bruising and bleeding of the gums and excess and sudden bleeding. Your nursing implications will tell you all of this, so make sure you look at those and that you read those. For example, you want to avoid taking over-the-counter drugs, especially those that contain those NSAIDs like naproxens and stuff like that. So because these increase the risk for bleeding. And those antacids, like the Tums that the patients love to take because it's nice and sweet, they interfere with the antiplatelet drugs. So teach the patients to take antiplatelet drugs 1 hour before or 2 hours after they take those antacids. So make sure you look at some more of those implications. And then you have those direct thrombin inhibitors. And with the direct thrombin inhibitors, those are your drugs that, these drugs bind to prothrombin and prevent its conversion to thrombin, which is needed to convert the fibrogen and the fibrin with less thrombin. So less fibrin is going to be available to form that network that is that mesh forming, which is the base of the clot. So you have your drugs that you're going to see, your Eliquis, your Xarelto. So make sure you're looking at the generic name for those when you're looking at those drugs, so you can learn the generic names along with those. And what are you going to watch for? So you want to watch for your signs of those abnormal bleeding. And you're going to teach your patients to report abnormal bleeding, especially if it's heavy menstrual. So you want to report that to the provider. And you're also going to teach your patients to avoid aspirins or NSAIDs while they're taking these thrombin and inhibitors, because again, it's going to those already have that effect to cause some bleeding, so it's going to enhance it even more to a more serious hemorrhage, and even death can occur. Okay. And what falls under these? So you have your, so those are your direct thrombin inhibitors, and you have them again. They do fall under certain categories. So I think this is this. So in your book, it's the direct thrombin inhibitors, and your indirect thrombin inhibitors will fall under the categories with your heparins and your, and some of your Coumadin. So basically, just really kind of look in your book. So your vitamin K antagonists will really fall under the category. The Coumadins usually fall under those categories. Again, I didn't make the slide, so sorry for what it says. So your direct thrombin inhibitors will fall under your Eliquis, your Xareltos, and all of that. Okay, so this should say indirect. The title of this one that you're looking at right now should be your indirect thrombin inhibitors. Okay? All right, great. Okay. And go to the next slide. Okay. And okay, so let's look at those indirect thrombin inhibitors. So your indirect thrombin inhibitors, again, what they do is, and that's this category, so you just want to put an IN in front of that direct. So what they do is these drugs indirectly prevent the conversion of prothrombin to thrombin by increasing the amount of active antithrombin 3. So this substance has the action of actually interfering with the conversion of the prothrombin and also the thrombins. So you're going to see your drug categories, you're going to see your heparins. And usually the heparins is given IV or subcutaneously. You're going to see under that same category, you're going to have your low molecular weight heparins, which are your Lovenox. You'll see that. And that's also, that can be given, also subcutaneously. Make sure you look at all your nursing implications within this category. So for example, you want to watch for signs of abnormal bleeding and teach patients to report abnormal bleeding, including heavy menses and so forth. And you also want to, monitor, you want to assess the patients who are receiving heparin for low platelet counts and indications of clot extension, because these are signs of some type of what we call a heparin-induced thrombocytopenia, which is a life-threatening reaction to heparin. Okay. So we're going to go over a little bit more. So some of the actions and the uses for those categories of drugs, again, to prevent new thrombus formation, stop existing thrombi from growing in size, prophylactic post-surgery involving the heart or circulatory system. Patients with heart valve disease and some dysrhythmias, and also patients receiving hemodialysis, and patients with prolonged bed rest or a history of thrombus formation. And of course, you're going to have some of your adverse reactions, like with the warfarin and Coumadin. You'll see the alopecias, the rash, the urticarias, cramping, diarrhea, intestinal obstruction, nausea, paralytic ileus, vomiting, excessive uterine bleeding, hemorrhage, leukopenia, and fever. And with the heparin, you'll see the hypertension, headache, hematoma, conjunctivitis, tearing of the eyes, rhinitis, hemorrhage, thrombocytopenia, dyspnea, chills, fevers, alopecia, persistent or prolonged erection, hypersensitivities. And then, of course, we'll look at some of the drug reactions, which are, and again, you always want to look at your nursing implications and patient teaching, okay, in regards to this. So when you're doing the heparin, the calculation procedure of the heparin is very critical. Again, you are monitoring those blood volumes, like the PT-INRs, like we said earlier when we were discussing earlier about looking at the PT-INR, and when the physician orders it, so like usually daily, they like a certain amount of time they're gonna like 3 days, 5 days, where they will go in and do these PT-INRs. So you want to make sure that you're getting the order from the doctor and doing the changes. I am going to give you a video to actually look at in regards to this. Heparin activated APTT therapeutic is 2.5 to 3, and you'll see the control value. So I'll give you a video to actually look at this and see this. And this is one of the things, if somebody's taking warfarin, it's an induced, they have that warfarin-induced skin necrosis, which you'll see, okay? And we did so, okay, so let me just go back. So you have your 4 classes of the anticoagulants, which is your platelet inhibitors, your direct thrombin inhibitors, your indirect thrombin inhibitors, and your vitamin K antagonists. Okay, those are your 4 classes of your anticoagulant drugs. And we did so. Okay. And also another safety alert for any patients who are taking anticoagulants, you want to watch for early signs of those bleedings where we just talked about. When it comes to drug and food interactions, so many of the anticoagulants, they have many interactions with other drugs and foods that can increase the risk for bleeding or decrease the effectiveness of the drug. So you want to make sure you look at that. Especially, platelet inhibitors such as aspirins and NSAIDs taken with other drugs that reduce coagulation can cause excessive bleeding. Any type of alcohol beverage can also increase the risk of bleeding. Other drugs such as vitamin K and oral contraceptives also decrease the effects of any of these anticoagulants. And when your patient is on antibiotics, they can have a variable effect of the blood clotting factor. We said that earlier when taken with antibiotics. One of your concerns would be looking at the green leafy vegetables containing vitamin K. These can decrease the effectiveness of anticoagulants, and a lot of the herbal products, vitamins, and supplements can also interfere with these anticoagulants. Your book does give an example like St. John's wort. It can increase the risk for bleeding, okay? So you want to make sure you're looking at all of that. Box 14.1, it shows the foods, the herbs, and the supplements that affect the clotting system, and those foods may interfere with anticoagulants. So make sure you look at these list of foods very carefully so you can kind of get to know them. And that includes your tomatoes, onions, dark leafy green broccoli, garlic, bananas. And it also gives a list of those supplements we just said. And one of them is we said something about St. John's wort and other herbs that increase the risk for bleeding. And so you want to look at that. And one of them under that category is actually green leaf tea. So when you're looking at the nursing implications and patient teaching, again, you are, before giving the first dose of any platelet inhibitor, it is very important. To ask the patient what other drugs he or she has taken in the past, including any over-the-counter drugs like vitamins and minerals and so forth. And you're definitely going to continue to assess for signs of bleeding And like before we said, the severe abdominal pain, the tenderness, the vomiting, the diarrhea, that is frank red blood or even coffee colored blood, or coffee colored. And you're also going to be looking for cold and clammy skin. One of the other things you want to look for is petechiae. You're going to look at the skin for that. Any type of tiny red purple skin blotches can mean or cause like minor that's bleeding out into the skin. Again, as you do this, make sure you get your planning and implementation going as you're doing that. So make sure you read that through and how to evaluate. And the same thing when you're looking at the direct thrombin inhibitors. So your direct thrombin inhibitors, like your Xareltos and stuff like that. So make sure you're reading the nursing implications in regards for that and what you're looking at and what you're assessing in regards to the bleeding and so forth. Your indirect thrombin inhibitors, again, those are the big ones, like your you have your Lovenox, and those drugs that you see here. Okay, so you want to make sure that you're reading the nursing implications for that. And let me see, something I wanted to tell you. Okay. So again, your expected side effects, especially with the heparin sodium, that can cause easy bleeding and the bruising and so forth. Your nursing assessment, again, when you're doing your assessment, the heparin itself is derived from animal tissue and is more likely to cause some type of allergic reaction than other anticoagulants. So when giving it to the patients who have a history of allergy, you want to observe them closely. So this drug could be used cautiously in patients with liver or kidney disease or hypertension after delivery, or in patients with indwelling catheters. So a high incidence of bleeding may be seen in a lot of your older patients, okay? And a drug alert, when you're administering the heparin, you want to make sure you roll the heparin bottle between your hands rather than shaking it. So do not give heparin in the same IV line or same syringe with any other drug. So that's one of your drug alerts that's there, okay? And again, when giving this drug, it shows in your book, deep subcutaneous injection for low molecular weight heparin. So you want to make sure that you are doing that. And also look at the top tip safety when giving these drugs. So when injecting subcutaneous heparin, do not pull back on the syringe to aspirate for blood or move the needle in the tissue during the injection. Also, do not massage the injection site. And all of these actions increase the risk for bleeding, bruising, and tissue damage at the injection site. So make sure you're reading this section in your book that's going to talk about with the planning, the whole implementation and administering the drug itself, okay? So now you have your vitamin K antagonist. And your vitamin K antagonist is necessary for the production of specific proteins that are needed in the clotting process, which are anticoagulant drugs that interfere with blood clotting or reducing the amount of vitamin K that is available to help the liver from forming any type of clots. In those drugs category, it's going to, you'll see, sorry, where am I? Okay, those are your warfarins, your coumadins, and so forth. So those are your vitamin K antagonists. And we just went through all of that from before. So again, earlier, all those drugs that falls under that category. So just make sure with this group of drugs, you want to look at your top safety tips, signs that suggest any type of internal bleeding, which would be abdominal pain or swelling, back pain or constipation, bloody or tarry stools, bloody or dark colored urine, and the dizziness and so forth that we spoke about earlier. I'm just emphasizing because these are the things that you really want to look at when you're looking at the vitamin K antagonist. So again, when you're doing the assessment, you're getting the complete health history from your patients, including their current health problem in regards to, prior to planning and implementing. Again, you really want to look at your whole planning and implementation when it comes to the warfarin or the Coumadin, because that's one of the drugs you'll definitely be going over. So basically, it's a really long list, so you really want to look at that, especially with the warfarin can have an unpredictable and variable effect in some patients, especially in older patients, 65 years and older, and those of Asian descent. And so, again, make sure you read that. Okay. So as a memory jogger, if the person's on heparin, if they're on warfarin, they can be taken at the same time, whereas most other anticoagulants cannot. Okay. Now let's look at the fibrinolytic drugs. Okay. And fibrinolytic drugs, that category is the thrombolytic category. So those drugs, when you see that, these drugs dissolve clots by activating the plasminogen or to plasmin, which is an enzyme that breaks down the fibrin or fiber network that is the mesh holding a clot together. There you will see your antiplace, and these are used usually for the myocardial infarctions or pulmonary embolisms and also a stroke. Make sure you look carefully at these nursing implications that they have, especially before therapy. You want to ensure the patient has no history of any type of active internal bleeding, like a recent stroke, for instance, or really elevated blood pressure, like 200 over 120. So you want to make sure, because these conditions are absolute contraindications when you're giving any type of fibrinolytic therapy. You also want to watch for signs of hemorrhage, especially bleeding into the brain, because these drugs greatly increase the risk for bleeding anywhere. So you want to make sure that you're looking at that. And you also want to avoid giving any type of iron drugs because of the risk for bleeding. And if these drugs are, if IV line is removed during this time because of the high risk for the bleeding, you want to apply pressure for at least 30 minutes. And these drugs are not given by LPNs. They're always usually given by an RN. So you want to look at, make sure, okay? So those fibrinolytics are usually given by a registered nurse or emergency person who works like an EMS or someone, okay? Because you have that TPA. So if the ambulance is called, these are like a really emergency drugs that are given, like, if you call and say that you think the person's having a stroke, these are medications that are given like during emergency. And again, it tells you that too in your book. It says the fibrinolytic drugs are used in an acute care setting, such as an emergency department or intensive care unit, okay? And they're given for a variety of reasons, including an MI, acute pulmonary emboli, acute ischemic stroke, acute arterial occlusion. And these drugs dissolves those clots and embolites, ultimately reducing the extent of cellular damage from arterial blockage. So timing is very crucial, a very crucial factor for these drugs. So if fibrinolytics are begun within 12 hours of a heart attack or 3 hours of onset of stroke, a blood clot blocking the artery can dissolve and the blood flow can be restored. So the most common used fibrinolytic drugs are the TPA or the activase TPA or the redoplase rectivase. So you'll hear those names, especially for emergency drugs. So you want to be careful not to confuse TPA and T and K, the T kinase, those two, T kinase. Although both are fibrinolytic, the dosage and also the administration are very different. And these drugs are high alert drugs and are given through an IV line, which means it has to be given by an RN or emergency person, okay? Then you have your erythropoiesis stimulating agent, okay? Those categories of drugs. Those coming in, I'm pre-recording this class right now, so make sure you're coming in on mute. So then you have your erythropoiesis stimulating agents. And again, you have those categories of drugs. You have these drugs, they basically induce the bone marrow to increase the production of red blood cells and also some other blood cells. So again, you want to look at the nursing implications of those. It's a very short list in regards to that. Some of those drugs, again, you have the epigens that the patient would receive. So you basically, you're going to monitor the blood pressure for increase due to increased blood viscosity, the headaches, the body aches, the fevers, and also the chills. So what are these? So this chart here says the colony stimulating factor. I guess it shows you those different areas and what it falls under, the actions. This is not in your book, but I guess they put it up here for something for you to review and look at. Let me see what it is. Nepogens. Okay. Now I don't see this in this chart here in your book. I have to find out what it is. But again, under those, the nursing implications in patient teaching. Trying to look at this and see what this is on your full top. Okay, I have to find out what that is in your chart, in your book. Okay, but you have all the nursing implications in regards to that category of drugs, which is your erythropoiesis stimulating agents. And what that do, the uses for that, again, these are usually given to patients with conditions that cause anemia, but who need to increase the production of the red blood cells. Patients with chronic kidney disease cannot make enough of those erythropoietins to provide adequate oxygen to their tissues. So patients who are anemic from the effects of, like, for example, the chemotherapy on the bone marrow, or who may be anemic before surgery, are often prescribed these ESAs. And these drugs reduce the need for transfusion and also reduce the complications of transfusion, such as, fluid overload. Okay. And again, make sure you're looking at the nursing implications for those.